Welcome to the IRP seminar. I'm glad you are able to join us today. We are Jetson. I've been instructed to introduce him just by his first name. So the chair of today will be Jetson. And Jetson is an assistant professor in the business school at Boston University and is an economist who does work on healthcare fraud. And we're going to get to hear about some of that today. As an economist, Jetson will be offended if you do not ask interrupting questions. So please cover him with questions early and often. And we'll turn things over to you.
Thank you so much for the wonderful introduction. Yes, I was threatened with a silent room and I was like, oh God, anything but that. But if I give more than 3 slides in a row without being interrupted, I no longer know what to do with myself. Hi, I'm Jetson. Thank you guys so much for having me. I present in a lot of places and this is certainly the most beautiful seminar room I've ever seen. So big props on that. This is a brand new paper called Competition and Fraud in Healthcare. It's with our great PhD student, Renika Dewan. And then a team of people, Paul Illison and Riley Lee, Ryan McDevitt and Jimmy Roberts. We've written some other work on fraud before, and this is like very new, so new that there will be incomplete sections. And I look forward to all of your feedback. I will say, I do, I'm here to hear from you guys. So, sometimes talks are advertisements and sometimes talks are about feedback, and this is certainly a talk about feedback. Okay, great. So let's talk about healthcare fraud broadly. The United States government spends $1 trillion a year on health insurance between the Medicare and Medicaid programs, probably actually a little bit more than that at this point. And a major issue is fraud. And here I've left some headlines from the Wall Street Journal, the Associated Press, et cetera, describing various healthcare frauds. And healthcare fraud occurs in basically every corner of the health insurance market. Here we have ambulances, Medicare Advantage, false billing in hospitals, pharmacies, nursing homes, you name it, and there's been healthcare fraud in it. And the main problem here from the perspective of a group like the Institute for Research on Poverty is that health insurance, particularly a program like Medicaid, for example, is actually a really important social safety net program. And so taking that money and rediverting it to criminals' pockets is probably a very inefficient use of public resources and can stretch these programs, which are historically not extremely well funded to begin with. And so combating healthcare fraud is an important part of public program design. And a lot of the work that I've done focuses on this, not just in the context of health insurance, but broadly asking questions about how we can ensure efficiency and eliminate waste and fraud in public benefits programs more broadly. And so I'm going to give a very self-indulgent slide that I apologize, but I want to catch you guys up on some papers you might not have seen that are going to be relevant for how we think about the thing that I'm going to do today. And I want to tell you about 3 studies. Okay, so the first study I wrote on healthcare fraud was about whistleblowers. And the basic idea was, how effective can whistleblowers be at catching healthcare fraud? And I showed that they produce big deterrence effects. And then I moved on to these 2 other studies that have the same flavor, which is there is a fraud. What can we do to enforce against it? And in this recent paper called Ambulance Taxis, we compare the effects of prior authorization, that is prepayment review, before the money goes out the door, against ex post measures of stopping fraud, like waiting till people commit fraud and then trying to catch them, and discuss the relative trade-offs of these type of enforcement mechanisms. And my work generally has this theme of I take some legal data on enforcement and I pair it with some data on healthcare fraud and try to understand what works and what doesn't work in considering stopping fraud. But it leaves open a very important and big question that I'm now trying to think about, which is, where does the fraud actually come from? And is there a way that we could design a healthcare system so that fraud is less incentivized? That is, these papers take as given that there are all these frauds and what can we do to stop them? And kind of this alternate question is, well, actually, is there something wrong with the program if it's being designed so that fraud is easy to propagate? And that's what we're trying to do here. And that's why we're going to start talking about market design questions like competition. So where does fraud come from? I'd like to say that fraud is often an information asymmetry problem. This is a very economist way of thinking about the world, right? Providers who provide the healthcare know more about the patient's health and know more about what they did than the insurer does. So they have an opportunity to lie, right? Because the insurer doesn't really know everything that happens in the exam room. Moreover, they have an incentive to do so. The federal government, despite spending $1 trillion on healthcare, doesn't largely run providers, right? We don't have a ton of government hospitals or government nursing homes or government, medical equipment companies. We have private companies that bill the government, and the government is really just an insurer here, which means that we have companies that not only have the ability to lie because of this information asymmetry, they have an incentive to do so, right? It's profitable to do so. And if they're either stretched thin or just trying to be profiteering, they have a strong motivation to lie on their bills in order to earn more money. And this is the way I've thought about this for a long time. But something came out of this last piece of work that I did on ambulances. And I'll just quickly tell the story because it becomes relevant. So the paper on ambulances, which is not today's paper, is about non-emergency dialysis ambulance transportation. These are patients who are on kind of end-stage renal disease. They're getting dialysis 3 times a week. They have to go to like a DaVita facility to sit there for 3 hours with a needle in their arm and get their blood circulated. And what happened is this fraud sprung up where thousands of ambulance companies arose to drive patients to and from these dialysis clinics at $250 for a one-way ride. This paper's called Ambulance Taxes. And what we talked a lot about how the government enforced against this and different things that they tried to do to stop it. But there's this other question, which is like, why are we paying $250 for an ambulance ride, for a one-way non-lights and sirens ambulance ride? If you gave me $500 per taxi ride, like 3 times a week for the rest of a patient's life, I might be willing to commit fraud. Maybe not me personally, but lots of people would, right? And so there's this thing that's going on here, which is about prices, right? Healthcare prices are regulated, which means that the prices aren't dynamic, which means that, if I found a way to sell $50 bananas, right, on the street somehow, like someone else would open a shop next door and start selling $40 bananas, and eventually the rents would get driven out. And we think of this competitive price pressure as a really important way to ensure that, basically prices don't stay above marginal cost in the long run. But that's not how healthcare works at all, right? If the government says an ambulance ride is $250 and an ambulance ride is $250, and if the marginal cost is $50, I might indeed go around paying patients to ride in my ambulance, which is what we saw in that paper. And so we didn't have any price variation there. But that's the idea behind this paper. It's this idea that if the prices are wrong, then the incentives to commit fraud can be very high. And so one of the ways in which prices can be lowered is through price competition. And that's what this paper is about. This paper is about price competition as an idea that the prices being wrong is a big driver of fraud. Lowering the prices might actually be an important way of eliminating fraud in healthcare systems. Okay? So the basic idea is price competition could potentially lower markups and therefore lower the incentive to commit fraud. If the service is less profitable, then providers won't be as eager to give it to patients who don't need them. That's kind of the basic idea here. Or if there's something about relative prices between a low service and a high service, and the problem is some form of upcoding, is giving a higher level of service than's needed or billing for a higher level of service than is given, the relative prices are also sort of an important part of that. And so getting the prices right is going to be an important part of eliminating healthcare fraud. That was the basic idea when we started this paper. But then we realized actually it's not obvious that price competition is going to make fraud better. Competition can also make fraud worse. We know a lot from studies of anti-competitive behavior and that prices and profits coming down, at least in the corporate world, has been allegedly a reason why CEOs backdate their stocks and people illegally collude and all sorts of other bad behavior. Is it possible that competition can exacerbate fraud? Yeah, potentially. Which companies are going to survive in a more competitive marketplace, or which companies are most willing to cheat or lie? And how does that relate to their cost structure? And so it's not actually obvious that reducing the prices makes fraud better. And so there's a trade-off associated in competition. Competition both eliminates some of the rents, making it less profitable to do any given fraud, but also can increase competitive pressure in a way that potentially selects on the wrong types of companies. Okay? So that's what we do in this paper. In this paper, we study the role of increased competition in either promoting or inhibiting fraud. And to do so, we're going to be talking about the Medicare durable medical equipment marketplace. I'll give you a lot of details on that in the background section. Medicare durable medical equipment rolled out competitive bidding. Oh, go ahead.
Nobody interrupted you.
I love it.
Can you tell us a little bit more about what you mean by fraud? So there's some things like if the patient doesn't exist and we're claiming or treating them, that seems fraudulent.
This is a super important question. I have a whole what do I mean by fraud slide? It's in 4 slides. So can I get there? I want it now. Okay. I promise I'm going to explain exactly what I mean. I want to be clear that I'm not talking about waste. There is a distinction between waste and fraud. I don't just mean a patient qualifies for a service and they got it, but ex post we're like, is that really a good use of our resources? That's not really what I'm talking about here. Fraud in the durable medical equipment market looks a lot like dropping off a wheelchair at a patient's home when that patient never even asked for a wheelchair and they can walk totally fine. Right? There's a lot of capital F fraud here. I'll talk about that in detail, but you should be thinking real bad behavior here and not just inefficiency. Okay. So, yes.
So I think you might be maybe you're going to talk about this when you get to your, like, here are the different kinds of fraud. But thinking about the incentive to upcode and the relative prices across services, you know, a challenge there is you don't know what service level is being provided, which creates weird incentives like
Super correct.
I want to avoid more severe patients if the relative price or the more severe service is not compensating me for the higher cost, or I might have a disincentive to invest in quality if
your intuition is absolutely correct. And the word quality appears for the first time on the next slide. So give me a second, okay? You guys are good, very good intuition. This is no, this is right. Okay. So competitive bidding here. What goes on is Medicare introduces price competition. Instead of saying, here's the price of a wheelchair that we pay for, they instead set up a system in which firms are going to bid, and the firms that offer lower prices are going to be the ones that are able to sell the equipment. I'm going to give you some institutional details about this procurement system shortly. But this is the introduction of price competition as explicitly a way of trying to lower the prices and reduce spending in DME. Okay? So we're going to do three things in this paper. First, we need to figure out what the fraud is. Big problem, all my papers, really would love to solve it. There's no fraud column in the Medicare claims data. It'd be really nice if they put that in. Because people who commit fraud hide it. And so one of the big problems is you have to kind of say, like, what's fraud, right? We're going to do some work here to talk about fraud. We feel pretty good about it, and I'd love to hear if you think what we do here is credible. Then we're going to use the staggered rollout of competitive bidding, which fortunately happened for different types of medical equipment in different cities at different times. So we're going to do a difference in difference to understand the effect of competitive bidding, that is price competition, on fraud that we've identified in step one. And then in step three, we're going to try to figure out why we find what we find with some mechanisms. I'll talk about that shortly. Okay. So preview the results. We identify 850 firms that were caught committing DME fraud, and learning about those firms, we're then able to identify about 2,000 other firms that did not get caught committing DME fraud, but it sure looks like they were doing it. Okay, and we'll tell you about what those firms look like. So we think that we have a good identification of the fraud. Competitive bidding, when rolled out, reduces total spending and prices and quantities. We replicate that result. That is not our original result. There are two great papers in this space. There's this Ding, Duggan, and Stark paper on CPAP machines. Those are sleep apnea machines that shows that prices and quantities fall. And then Yunan Ji's whole job market paper was a big evaluation of this competitive bidding program, and it has a whole model of the auctions and stuff like that. And she also shows that prices and quantities fall, but neither of those papers talk about fraud. They're just like what happened when there was competitive bidding. Okay. What we actually find is that this fall in prices and quantities masks important heterogeneity, and in particular, fraudulent firms are going to gain market share through increased competition, which is not what I thought I was going to find when I started this paper. Legitimate firms are the ones that are actually tanking here. Okay, Ashley.
I'm kind of curious, like, do you think the impact of fraud on competition on fraud depends on the competition mechanism? Because this is an auction.
For sure.
Which is going to steer market share towards a subset of firms in a different way than competition, price setting competition for trend style.
I think that's true. So this is a good point. So I'm not going to be able to talk about every type of competition, right? So if we were kind of like think about the whole way in which we study competitive pressure, I'm not going to be able to say anything related to like vertical or horizontal integration of firms. Right? There's like a lot of questions about competition that look like vertical or horizontal integration of firms. I don't think that like that's a whole literature we're not going to be able to speak to. I think what we're going to show is it looks a lot like price competition at the end of the day. I don't think that the auctions are they're very bad auctions, and I'll tell you about them. They're like sort of hilariously bad auctions, but it really just kind of feels like price competition. At the end of the day, it's just like the firm that offers the lowest price is the one that really gets to sell. So it's not, I think Bertrand is like a good first order model. There are some quirks about that, but why are you afraid that it doesn't look like normal price competition?
Well, I think in auction, I'm not saying this isn't price competition. I'm just saying a market with auctions where it's winner take all or some take all might be very different along this dimension than a market where all firms are allowed to participate, but they're setting prices and quality.
That's a good point. So there is we're going to talk about whether or not the upfront screening mechanism used here will maybe privilege bigger firms or something like that, because there's overhead costs is kind of the way that we're thinking about this. I will get there in my mechanism slide. I don't think that the auctions are functionally winner take all because of how they work, and I'll talk about that in a second. Go ahead.
Are you going to talk a little bit about
how the fraud is detected,
Yes.
what the probability, because I'm thinking like the flip side of this is like, we can disincentivize this through competition, or we can disincentivize this through the penalties and the likelihood,
Yes.
right? So.
Yeah, so I can tell you everything about how fraud is detected in the legal system because I've written like a bunch of papers that are like, here's how we catch it, here's how we prosecute it. You have civil penalties, you have criminal penalties, you have administrative penalties, etc. I would say that this paper tries to move away from those questions because I've done a lot of work on it. Quickly, there are a bunch of ways in which we penalize fraud. So there's a whistleblower system that results in federal civil cases where the whistleblower gets a share of the money and then the government gets back triple damages. There are federal criminal laws that make it illegal to overbill that can result in jail time as well as criminal restitution. Generally, they're very effective against large providers. They tend to be less effective against small providers because you can't get any money back from a company that's small. It's kind of one of the things we've shown. They tend to also have pretty big deterrence effects, which is that people respond to seeing people that are committing fraud get thrown in jail. In the background.
Give me a sense of why quantity fell when they introduced competition via the hub, like simple model is like the markups come from.
Yeah, so a few things. The first is that it may be a little bit, so a few reasons. The first is that if you make something less profitable and the supply curve slopes upward, then fewer people are willing to sell. Kind of the basic one. But the other is that through the mechanism of determining who's able to sell, there were these sort of like, we're going to buy this many quantity and price. Yeah. Which goes back to kind of Ashley's question, which is like how generalizable. I think it's a problem, right? We're not going to be able to say everything we want about all forms of competition, but this is one we get to see. So
I didn't say it was a problem.
it's a limitation. It's a limitation. Right? So the fact that fraudulent firms gain market share here tells us that there's like this trade-off between lowering prices is good because it makes there less incentive for fraud. Lowering prices could actually make firms compete in a way that's not welfare enhancing. In particular, we think it's going to benefit the wrong firms. Why? Why do fraudulent and suspicious firms gain market share? We've thought about a few potential mechanisms here, although here's where I'm super interested in hearing more from all of you guys. So the first is it's just a firm size effect. Suppose that bigger firms are the fraudulent ones because committing fraud makes you a lot of money, and now you're a big firm. And then I throw a big hassle cost at everyone, and then only the big firms are able to survive. Right? That would be a world in which the big firms happen to be the fraudulent firms, and the bigger firms can survive competition, and so we're actually selecting on the fraudulent firms, but we're really just selecting on the bigger firms. We're going to explore this, and I'm going to be able to say that certainly there is a firm size effect, but it doesn't explain all of our results because we see legitimate big firms are not doing particularly well. Okay. The second is something about anti-competitive behavior. There's an interesting literature here that I'll speak to in a second about like maybe firms, when faced with competitive pressure, engage in anti-competitive behavior. In this case, the primary mechanism I'm interested in is like bid rigging, right? These are auctions. Auctions have collusion problems. Maybe the illegitimate firms are like gaming the system. And we see all sorts of questions about anti-competitive behavior, or is maybe being good is some sort of a normal good, right? Like, and when profits are high, people behave nicely, and then you bring profits down, and everyone kind of pulls out the daggers, and then there's some anti-competitive behavior. I'll talk a little bit about how we can explore that. And then the one that I think is really interesting here is going to be about quality. And the idea is that it's possible that these illegitimate firms are the low-cost firms. Talk about why I think that is. And that if they're lower cost, then when we just reduce prices, they're better able to compete. So it's actually, we're selecting on the fraudulent firms fundamentally by reducing prices. And I think that that's sort of the avenue. I think all of these are going to be a factor at the end. It's not going to be like pick one. I think it's going to be like all three. But I think that last one is where kind of the meat lies. Stuart.
I'm actually not totally clear on the difference between 1 and 3. Like, it seems like you're able to provide lower costs. You get to be a big firm by kind of doing too much and then covering more fixed costs, and maybe other firms can't compete with that.
Yes.
It seemed like.
I'm going to say it can't just be about the fixed costs. Think about the fixed cost versus marginal costs is the difference between 1 and 3. And it's not all fixed costs story. Is the argument I'm going to try to make. Make sense? Actually.
I have one really important comment.
Yes.
Is that there's a new TV show on Apple TV called Bad Monkey, which is all about DME.
Yes, everyone has told me about this. I've been told I have to watch it. I'm about 25 years behind on TV. I just finished The Sopranos. I don't really watch TV. I will probably get around to it around 2050. So, but thank you. I'll put it on the list. Okay, great. So this paper sits in 3 literatures. The first is on healthcare fraud. I mentioned a couple papers. I want to mention also that there's some really excellent work. Maggie Shee has this great paper on the Medicare audit program. There's been great work by David Howard on healthcare fraud as well in JHE. The seminal papers by Limor Daphne and the Silverman and Skinner paper on hospital coding that you might be familiar with from way back in the day. Hending Fang and Qinggong have this paper on detecting healthcare fraud. So there's like a lot of kind of like, how do we think about fraud and waste in the healthcare system here? The second is there's this literature on DME auctions. There are the 2 empirical papers I mentioned that talk about prices and quantities. There's also been some really good theoretical work on these auctions because they're kind of funny, and I'll tell you about that in a second. And then finally, I think this paper is really more in the questions about the provision of public goods. There is great work, for example, the Hartschleifer and Vishny paper on private prisons that you might be familiar with, that asks questions like, how do we ensure in an incomplete world of incomplete contracts that private firms that provide public goods actually provide high quality goods? And when we get to the quality section, I'll talk a little bit more about this. Okay. So durable medical equipment, it's giving products to Medicare beneficiaries. Think home beds, oxygen equipment, walkers. It's about $5 to $10 billion a year program, so pretty substantial. The basic idea is there are referrers who write prescriptions. Those are physicians who see the patient and write a script. And then there are these DME supply companies that are responsible for basically selling the walker or something like that. The doctor is supposed to sign off on medical necessity. That's the treating physician is going to be like, yes, this person needs a wheelchair. Okay. Fraud has been rampant in DME for years. It continues to be like the Wild West of fraud in healthcare. I'm very excited to just be talking about it. It's hard to know how much fraud there is, like always, but there's this thing called improper payments. Improper payments is how much of the spending wouldn't pass an audit. So it's not all fraud. Some of it's missing documentation. Some of it's like the checks were cut for the wrong person, et cetera. But DME improper payments have been 20% for like more than 10 years, which is like ridiculous, right? This is higher than the rest of the Medicare program. It's higher than most of the government. And so we think that means there's a lot of fraud, or at least a lot of opportunity for fraud. The basic fraud here is you give equipment to patients who don't need it, or you don't give them anything. But this idea is that you have some patient who either doesn't need a wheelchair or doesn't need a walker or doesn't need some sort of medical equipment. You get a doctor to write a bogus script after a 2-minute telephone call or a telehealth video Zoom call. Oh, yep, you need a walker. And they write a script. The fraudulent DME companies are generally recruiting these patients, getting these doctors to sign on, and then selling as many of these things as possible. So it's really a medical necessity fraud is the type of fraud that we're talking about here. There is also some allegation of upcoding. That is, you're going to take a patient who does need kind of something, but you're going to give them this super primo thing, bells and whistles, et cetera, just because it's more expensive. And so there's been some of that as well. Going back to your question here, there's been extensive nationwide enforcement efforts to crack down on these frauds. There have been whistleblower lawsuits. There have been criminal cases. There have been mass arrests. There's been like everything. We've tried everything for years to try to cut out DME fraud. DME fraud is still a huge category. I spoke at the National Healthcare Anti-Fraud Association, which is basically like the head of enforcement at the DOJ, the OIG, the FBI, Aetna, United, Blue Cross, et cetera, in a room like 2 weeks ago in Washington. And I was telling them, oh, and I have this new paper on DME fraud. And there was this like collective groan, like, oh my God, we're still doing DME fraud. Because like the stuff I'm going to show you here is like spanning a really long time period of like DME fraud in 2005 and DME fraud in 2008. And like it still happens. So to this day, DME fraud is the Wild West. Go ahead.
Is there a secondary market for this DME equipment? Like what happens after people who get it, who don't, I don't know, just curious.
Yeah, so some of it gets sold like on eBay. Some of it gets returned to the manufacturer, and then there is a formal market for used equipment. Some of the fraud is they go back and they collect the wheelchair from the person who didn't need it, and then they resell it as though it's new to another person. So lots of juicy sort of opportunities in there for fraud. Go ahead.
I guess one thing I'm thinking about on this slide, it's related to your mechanisms, is you might think that a bigger firm either has more sophistication to navigate sort of the regulations and kind of know what the rules are. And if they're worried about audits, potentially make more money with a smaller fraction of what they're doing overall being fraud.
I hear what you're saying. I don't know how you think it's going to impact the results.
I think it's a reason that the fraudulent firms
Win?
Yeah, it could be doing better, I guess.
Yeah, so one thing that's hard to disentangle because we can't see inside the firms extremely well is like maybe this is like really good managed, really well managed, private equity owned, sophisticated firms that are both well managed and willing to commit fraud, but it's really hard to get at that. Yeah. Again, because like, what do you see in claims data? But I'll tell you a little bit about how we're identifying fraud. Go ahead.
I have kind of an ignorant question, but I'm just trying to get my head around how to think about how fraud happens in these firms. We're talking about fraudulent firms. Should I be thinking about firms that as a matter of policy engage in fraud? Like they sit down in a room with all of the executives and say, hey, let's do fraud.
Yes.
So it's that. It's not like, because I think of it as like, this happens because an individual
Yeah.
decides.
In some circumstances, in other frauds, not DME fraud, that's exactly the right way to think about it. You have a big national chain and some doctor decides that they're going to play games and then they get in trouble. That's not the case in DME. In DME, it's like systemic corruption at the firm level. And I know that from off the record interviews with owners of DME companies that I shouldn't talk more about. Go ahead.
What about the physicians, like the ones signing off on
Yes.
that? What happened to the 800 firms that were caught in fraud?
I'm going to use the physician information to detect fraud, and give me a minute on that. The physicians rarely get in trouble. That's a matter of legal policy. It's hard to get a physician in trouble for this sort of thing, because you're going to go and you're going to say, you wrote a script for this patient that said they needed a wheelchair, and they didn't. And the doctor's going to go, well, I thought they did. And then you're in like legal hell, right? Because it's very hard, actually. There is an open matter of unsettled case law right now, which is if one doctor says that a patient needs something and another doctor says that they didn't, can that be a fraudulent claim? So this came up in the hospice industry in this case called AceraCare, where you had for-profit hospice chains providing care to patients who they claimed were eligible because they claimed were dying, and other doctors were like, the patient isn't dying. So what happened is the 2nd and 11th Circuit courts, which are different parts of the country, disagreed on whether or not, as a matter of law, they've committed fraud when the physicians disagree. It went to the Supreme Court. Supreme Court declined the case 2 years ago. So right now, in some parts of the country, that's fraud, and in other parts of the country, it's not fraud. But it's really hard to go after a physician for medical judgment. So we tend to go after the companies who are also required to have information because they're doing it so flagrantly into so many different people that sometimes it's easier to get the company and to shut them down. Go ahead.
Okay, last one on this. What's like the market structure for DME? Like, do you have firms sort of selling DME at different, across different product lines, and are they doing the same kinds of things across multiple product lines?
We're going to think about fraud as occurring at a firm level, but yes, in practice, companies that sell fraudulent wheelchairs are often also selling other fraudulent products. They also, there's this big problem, which is like a lot of the behavior at a firm level can be natural. Go ahead.
On the last point about crackdowns, on the arrest side, you just explained why the clinicians, it's hard to get them.
Yeah.
What's on the firm side? Why is it hard to get them arrested? And
It's not. So I have 800 companies. I'll have it in the stats in a second. 800 companies have gotten busted for this. The real thing is it's very easy to open a DME company. So you have this very diffuse fraud, right? So I have this other paper, the same ambulance paper. Ex post enforcement is generally a poor mechanism for cracking down on diffuse frauds against small firms, because you go in, you raid them, you shut them down, you put the executives in jail, you recover no money, right? Because what do they have? They have like an office suite somewhere, basically, and some computers and maybe some equipment in a garage, but not really enough for the government to get back its millions of dollars. And then someone opens another one the next day across the street. And so I don't want to get too much into the enforcement space because it's kind of a different paper, but enforcement tends to be less effective when it's easier to open a firm. I think enforcement's really great against the hospital. You get a hospital on $100 million fraud, they're going to pay it because otherwise you're going to take all their MRI machines and shut them down and seize the building, and they have there's like money on the balance sheet. DME equipment, it's a very small firm, which means it's harder to enforce penalties against.
but the executives are in jail for a long time. You're actually
a lot of the lawsuits are civil lawsuits, so we're trying monetary penalties only. So then there's no jail time. There have been some people who've gone to jail for it.
this margin of converting the crackdowns to being arrests of the executive.
So it's harder to run criminal cases. So in federal court, the burden of proof for a civil case that's money only is 51% preponderance of the evidence standard, which means that it's pretty easy to get money back from a fraudulent firm. Criminal case, we're talking about beyond a reasonable doubt. So if you have the FBI investigating, they're going to like surveil and they're going to raid. And so it's harder to run a lot of those cases. They're not as scalable. they're much more expensive to run. And then you have to think about the opportunity cost of the FBI and the DOJ in doing that instead of gang crime and immigration crime and drugs and all the other things that they're supposed to do. Okay, so the Medicare program decided to run procurement auctions for the right to supply DME. They rolled this out by MSA, Metropolitan Statistical Area, in different waves. And so we actually have variation with different devices and regions and timing covered at different points in time. Really ideal variation. It looks like this. It's really nice. And then actually this isn't on this map, but it ran out after a few years and then they restarted it. We use the full-time variation of this. It's really well identified, which is really good for us. I love when your treatment map looks like this. This is really great. Okay. So we have great data for this project. We start with 100% sample of DME claims data from 1999 through 2019. I can see every dollar that was paid to a DME supplier for every Medicare beneficiary on Part A and B fee-for-service Medicare. I then merge with this, we have firm level data from two sources. The first is you can take these claims and you can aggregate them up to a firm level. We also have the NPPES, that's the provider enrollment data, which tells us about firm addresses and owners. There is a third data set that you might, if you know a lot about healthcare data, think would go here, which is called the PACOS data, which is the provider enrollment and chain data. So we got that. Spent a lot of money on it, and then it's garbage. It's really bad, unusable. Spent like 10 grand on it. I'm really upset. We're not even gonna touch it. Really bad. So sometimes you lose, but this is good. This is gonna be enough. And then we need to know who committed fraud. So we mine through the Department of Justice press releases. So every time the Department of Justice has a win, they like to talk about it. So we collect all of that and we look for people talking about DME fraud, and we hand collect information about fraudulent firms that are named in these Department of Justice press releases. Firms also can face administrative sanctions either on top of this or separately from the Office of the Inspector General of Health and Human Services. In general, they'll be excluded. They'll be told you can no longer participate in the Medicare program. That's like an administrative criteria. That list is public, and so we also have the information on firms in the exclusion list. And we're going to combine those, and the union of those two sets is going to give us the firms that were known to have committed fraud. We also have incredibly rich qualitative data. We've grabbed like lawsuit data off the federal court record about all of these cases and read through like dozens of them. And it's like fascinating stuff. I could talk all day about the sort of things that they're doing. But you might remember, or some of you will remember, that you used to see advertisements for wheelchairs from something called the Scooter Store on late night television. They're in the data set. So that's generally the nature of this sort of beast.
Excluded firms are only ones that committed fraud. There's no other reason for you to be excluded.
Generally, you have to have a criminal conviction or a pretty bad civil settlement to get kicked off the Medicare program. You also could theoretically get in trouble for like drug diversion, which isn't fraud, it's a different thing, but these aren't pharmacies, so we're not really too worried about it.
You're using that to like your.
Yeah, there are a lot of people on the exclusion list who've done, like if you're a physician and you commit a heinous felony that isn't related to this, you might be on the list, but we're looking for DME companies. And so generally it's pretty clean set. Go ahead.
Talk about who you might be missing. You know what I mean? We talk through who you might be missing.
So we don't have any of the firms that didn't get caught. That's the next slide. So the real thing is I don't want to just give me 2 slides. So there's a lot of people I'm missing, and that's exactly the point. So thank you for the prompt. Okay. So these are the firms that we know committed fraud. 2 sources. Give me 1 second. The DOJ named firms are in blue. The excluded firms are in red. Some firms are both. They're in purple. But we don't have all the firms that didn't get caught. And this is a real problem. Go ahead.
You're saying firms, not individuals. So
That's correct.
I'm a small business person and I have 3 companies.
I'm about to talk about this. Okay. So this is exactly my problem. Not all fraudulent firms are caught. I would argue most fraudulent firms don't get caught for lots of reasons. One of which is it's hard to run a lawsuit, or they just don't figure it out. There's been a lot of reasons why, we've caught 800 firms doing this. There are many firms that didn't get caught. And that would be a real source of bias if we just look at the firms that had gotten caught. You can't do that. They're different. Maybe they're the sloppiest ones, or maybe they're the best of them, or maybe they're the worst of it, right? It would just be not representative. So what we're going to do here is we're going to take the firms that got caught and then learn from them, get information about those firms to try to figure out who didn't get caught, and then lump those all together into fraudulent firms. And fraudulent firms are going to be both the ones that we know committed fraud and the ones that look pretty bad, and lump those together. So this comes to your point. The first is we're going to look at firms that share the exact address with a firm that got busted. And you'd think that wouldn't be that powerful, but it is, because you have some firm gets raided by the FBI and you get a Department of Justice criminal prosecution and settlement, and they blast it out, And then we go look in the enrollment data and there's like another DME firm at the same address that never got caught. So like, we're gonna use those firms as fraudulent. Talking about small companies that own multiple, we're gonna look at firms that have the exact same authorized owner. So the person in the enrollment system who owns this firm also owns another firm down the block. And we're gonna be able to look at those firms. And then finally, talking about the role of physicians here, we're gonna use the referral data to identify other suspicious firms in a very simple way. If you're a firm that got busted for fraud, I'm gonna look at the doctor that wrote the bulk of your prescriptions, the number one doctor to have written referrals to you. And I'm just gonna go one item, I'm gonna look at the firm to which that doctor has written the most referrals that did not get caught and call them suspicious. So it's a very simple algorithm here. Go ahead, Ashley.
Well, I just have a question to help us think about how this relates to what you ultimately do with this data set. Are you thinking about like, what is the performance of these firms in the auction? How much market share do they get? You mentioned market share. Are you thinking also about like the behavioral fraudulent response to in the
There's
auction?
gonna be a selection and a treatment.
Okay, great.
This is just to identify who we should be looking at as the bad ones.
And should we be worried about additional scrutiny being on these uncaught but suspicious firms? Like, does somebody else think they're suspicious? And is that gonna bias the treatment effect?
I don't think it's gonna bias the treatment effect because I don't think that the other firms getting caught is not gonna generally be contemporaneous with the price treatment that I'm interested in. We are doing some robustness checks right now to see that everything goes through if you only use pre-competitive bidding measures of suspiciousness and stuff like that, just to make sure it's kind of like a cleaner cut. But this is harder than it sounds, just because of kind of like data scale issues and like name matching is. But it's actually a really good point, right? Which is like, I'm not too worried about bias right now. The other thing we can do is I'll show you some statistics on these firms and they generally do look kind of bad. So go ahead.
I was just gonna ask, like, this is kind of related, I think. Being a fraudulent or suspicious firm is like a fixed characteristic. It could be the case that all of those firms get a bunch of market share, but then completely clean up their act.
Exactly. So that was sort of Ashley's point, right? Which is that there's both a selection and a treatment effect. So give me a second to talk about select. I have no interesting results on it, but I know that I have to. So that's, you'll give me some grace there. Go ahead.
So I'm still struggling a little bit with the identification of the fraud, because to me, it sounds like there has to be an interaction between, like, a firm can't commit fraud independently. They have to have a physician that's in on it. So how does that come into your measure?
Right. So
What is and why only at the firm level?
So you're absolutely correct that physicians have to be complicit because they need someone to write the script, right? The challenge here is it is not possible with claims data to say that a patient should not have received a device or something like that. It's very hard to measure that, at least at an individual level. Why? Because maybe you got a wheelchair and like you fell. Like it's like hard to know, right? That's not necessarily legitimate, that any individual person. And so the goal of this is to say, using the universe of firms that got busted, which means we have a pretty good sense that they were bad. We're gonna just try to infer who else is egregious. We're gonna miss some. Absolutely the case. There are going to be some firms that are really, below the radar that may get lumped in with the legitimate firms here. What I'm going to show you is that there's such a striking difference in patterns between these two groups, the groups of known bad and firms that look like them versus everyone else, that we're going to be able to say something meaningful about the effect on the fraudulent firms, understanding that we're fundamentally going to miss. Okay. So we have 150,000 firms that supply DME in the country. We found 846 that were caught, and we identified 2,300 that look suspicious. I'm just going to collectively refer to the bad firms as fraudulent firms, although I mean known fraudulent and fishy looking. You might also call them bad and good, et cetera, but I'm going to call them fraudulent and legitimate. We can produce firm level statistics. Again, we have excellent data. Suspicious and caught firms are big. So this is our revenue over the life cycle of the firm. Suspicious and fraudulent firms are about an order of magnitude, about 10 times bigger than the legitimate firms. They tend to sell a lot more products, but there are a lot fewer of them. Okay. We're increasingly doing work to validate these measures. I'll talk about some patient level stuff that we're going to do in just a minute. Okay. Go ahead.
Of the 2,345, how many came from each of those three
That's a great question. I don't know if I have it broken out by that. I think it's a lot of the first two. So we've rerun this on just not using the referral data at all and just on the like, are you literally owned by someone who got busted by the DOJ? And we get basically the same result. So it's not super sensitive to the identification of fraud measure, which is kind of ridiculous, right? Because you think that they could do a good, like they have all the data that we have, they have better data than we have at the Department of Justice, didn't do this. Somewhat frustrating. Okay, so we're gonna run a very standard two-way fixed effects, non-parametric difference and difference. So we're gonna use the fact that the timing of the rollout was varied across different product categories in different statistical areas in different months. And so this is sort of a standard two-way fixed effects. We're gonna look at the MSA, that's geographic region, for product H in quarter T. I'm gonna omit your -1. I'm gonna go from -K to K, which is we're gonna do 8 quarters before to 8 quarters after. We're gonna look at just the effect of being subject to competitive bidding, and then we saturate with product time, product MSA, and MSA time fixed effects. So the 2x2x2 fixed effects. I will say that it was really hard to run this early in the project because when you take 150,000 firms, and we were doing it at the month level, we tried to run everything at the firm month product, and there are 10,000 HCPCS codes or something like this. It got to be like a 2 billion wide panel, and then we blew up the NBR servers and got a lot of nasty emails. And I apologize to those of you who I've crowded out. And then we realized that actually what we needed to do is collapse it. So this is fundamentally at a less granular level. This is at the quarter level. And we're just going to break it by fraudulent versus suspicious. And it just has to be done that way because if you get, it recovers the same parameters to group that way. We've kind of shown it to ourselves. But we had to roll up. Otherwise it gets just intractably large. Go ahead.
Firms can go in and out of product H.
Yes, but it won't matter because we're just going to basically do the equivalent of zeroing them out of the panel if they stop selling something. We're not going to cut them. We're not going to stop observing them. We're going to observe them selling 0.
If they ever
yes
went over the 8 quarters and ever they're in.
Yes. And then what we're going to do is we're going to sum this up to the total being sold by the suspicious and fraudulent firms versus the total being sold, and then the zeros matter even less. Go ahead.
Firms are across markets. So
yes.
Are there any firms in all the markets, or are there any firms that
there are some firms that are not national, like Scooter Store. And so, but we're going to think about treatment. Treatment occurs at the beneficiary zip code. So we map from the beneficiary zip code into the MSA. And then we're going to talk about treated versus untreated products. Okay, so this is a replication result that just shows at the timing of competitive bidding, total revenue goes down for the treated product categories. You can do this in logs, you get the same thing. You can do this in prices and quantities, and you get something that splits out reasonable. This is a beautiful event study, but it's just what was already published by Okay? This is what's new. So here, what I've done is I've broken those numbers into amounts by fraudulent firms versus amounts by legitimate firms. And what we see is that there is a much bigger reduction among the legitimate firms. And this holds up if you do it in logs, or I think we do it in ACINCH. It also holds up if you do it as a number of firms, as a share. So what we see is that these effects that we see in blue, which is a replication of what I just showed you before, are primarily being driven by legitimate firms that are more likely to exit and are earning less money, which is very worrisome, right? This says that the introduction of price competition is hurting the legitimate firms more than it's hurting the fraudulent firms. Prices are still going down for everyone. Revenue is still going down for everyone. But because of that, market share is going up for the fraudulent firms. Price competition is selecting on the fraudulent firms who are then gaining market share. And so this is sort of our main result. And we've done this broken out by the known fraudulent ones versus the suspicious ones. We've done it as a share of number of firms. This is a number of firms that looks exactly the same. We've done it, here's where you break it out. Mostly this is the ones that didn't get caught. See this big increase? That's mechanical because if you get caught, you have to leave, right? But overall, what we're finding is that this, I'll click on another button. Here's it in number of firms. The fraudulent firms just aren't exiting. It's a lot of exit by the legitimate firms. And that is extremely worrisome because it means that prices going down isn't necessarily a good thing. Go ahead.
Fraudulent and legitimate firms sell the same products?
Generally, well, everything's at the product level, right? Because it's at the product quarter level. So we correct for that. On average, no, you would imagine that there are some products that are more valuable than others. But we don't think that biases our results because we have product level. Okay, so why? That's the question. So if you believe this, and I hope you believe this, because we spent a lot of time to get here. Now we're like, okay, but why? Okay, so here are 3 reasons that this could be. The first is this hassle cost story. Do I go to 115 or 130? 130, thank you. Okay. I speak fast, so I'll try to speak less. Perhaps fraudulent firms are bigger, right? And so what's actually going on here is it's just a scale thing. Fraudulent, it's just like a total red herring, and big firms are winning and small firms are losing. Could just be that, right? That could totally explain these results. Yes.
So thinking about the different ways you could get tagged in your algorithm. And this is not that I don't believe the results. I'm just trying to think of like how big, like, it seems like there are ways that bigger firms could creep into the suspicious
So
category.
let me talk. Yeah.
Yeah, their bigness.
So what I would mostly worry about is that if big firms are more likely to have some amount of high share from a suspicious referral, the referrer channel would be the one that I'd be most worried about, because that has something to do with like flows and network and stuff like that. Authorized owner, less so, right? Like if you're just owned by the same person that owns this, like there's no reason a big firm is more likely to be owned by someone who got caught than a small firm. I don't see an obvious mechanism there. So we've rerun the previous result only using the worst one, which is like same mailing address or same owner, and we get the same result. So
Is there any way to think of an intensive margin versus an extensive margin here? Like you are suspicious if any part of you ever looks suspicious.
Sure.
But you know, if you're talking about the really big firms, like they have multiple
that's
offices.
a very good point. I'm going to talk a little bit about measuring that with patient level data when I get to quality. But it's exactly what we need. Yeah, it's a very well taken. Go ahead.
It's just a clarification that, so you identify your firm engaged in fraud or not before this competitive bidding?
Yes. Well, no, so we use data from any year that the firm got caught. Okay. We think of fraudulentness as being sort of a firm level immutable characteristic in my mental model. We are now rerunning it with just using the pre-period data, but I don't think it affects anything. Okay. So 1, maybe it's a scale. 2, maybe there's something here about anti-competitive behavior, right? Maybe fraudulent firms are willing to cheat more on the process. Like they're willing to bid rig more. These auctions aren't very good. So we'll talk about that in a second. They're really actually very badly designed auctions. And so maybe there's something about collusion and gaming of the system. And there's an interesting literature there to speak to about anti-competitiveness. There's a great AER Papers and Proceedings by Andre Schleifer in like maybe 2005. That's like competitive pressure causes people to engage in bad behavior. And we see this in all sorts of markets, right? And Volkswagen cheats on their emission standards, right? And maybe there's something about this anti-competitive behavior that is being induced by these auctions. And the third is this idea about quality. Maybe fraudulent firms are low cost because they're providing a low quality product, where I'll define what I mean by that shortly. I need to be very specific. Low quality product might be either literally it's a garbage wheelchair, or they're not giving any wheelchair, or maybe it has something to do with the type of patients that they're serving. I'm going to kind of bake this into an idea about quality. Okay, so I have these kind of 3 things. I'm going to now punch them up. First, firm size. Okay. Maybe bigger firms can just deal with competitive bidding. Fraudulent firms are big firms. It's just about firm scale. It could be about fixed costs associated with the bidding mechanisms. It could be maybe they have better managers, and so they're growing more, and they're also winning these auctions, et cetera. We can rule out the idea that this effect is just due to big firms surviving with the following graph. We take the big firms and we just look at the big firms, some of which are legitimate and some of which are fraudulent. And what we see is, this is the market share graph again. If you look at the legitimate big firms, they're actually doing better than other firms. They're more likely to survive, but they're not gaining market share. And so that tells me that firm size certainly helps. Big firms are going to win this competition a little bit more, but they're not going to grow. And that means that there's something about fraudulentness that is privileging those fraudulent firms that isn't just a firm size factor. So I can rule out that it's the only effect. One thing I worry that this is going to get to is people are going to say put weights on each of those 3 bullets, and I don't know how to do that, right? Put weights on these 3 bullets. But I'm going to say the first one does not explain it alone, but it seems like it explains it a little. Okay. The next question is about anti-competitiveness. fraudulent firms may be engaged in anti-competitive behavior. And in this context, that would mean bid rigging. Let me tell you a little bit about the DME auctions. Does anyone know about these DME auctions? Okay, the DME auctions have been described to me as the people who run the Medicare program heard a bunch of economists talking in another room through a wall and wrote down some stuff and ran an auction. So the DME auctions have lots of problems. And there's a great paper here by Zeibo and Škoda that talks about that they're really bad. So the first thing is, I'm assuming everyone here has like an undergraduate microeconomics, at least basic understanding of what an auction is and how it works. They came up with something totally new and just made it up out of the box. So one, it is a median price auction. There's no such thing as a median. It's a median price auction. What's a median price auction? Literally, they just like look at all the bids and the median price wins. Why? I talked to some people involved in this, and they said it was their understanding that they were required by statute to use all of the bids in order to come up with the price. Now, I believe the second highest bid uses all of the bids. They do not believe that the second highest bid uses. So the canonical good auction to an economist is the second highest bidder. It's like second price auction. It's kind of a thing. They said, no, we have to use all of the bids, and second in the list doesn't use all the bids. That's sort of a philosophical disagreement. So we're going to use the average. But we can't take the mean. They at least knew that. They were like, but means have, what about outliers? So they said, we'll just go with the median. The median, it's like not subject. And so that's like, there are no good statistical properties associated with the median in a bid. It's a bad idea. The second is that these are non-binding auctions. That means that you can bid in the auction, win, and then go, I'm okay, and just back out, which plenty of firms did all the time. That induces all sorts of crazy ideas. You can suicide bid. You can bid like 1 cent and then drive the median down so that you win, and then uncommit if you're not making money. They're really, really bad. Okay, so how do you assess this? One of the issues here is if I want to do a bid rigging test on any good auction, federal communications spectrum auctions or some good, well-designed auction, I would take some out-of-the-box software on auction bid rigging by like Leslie Marks at Duke or one of these people that works on it, and I'd run that, right? And I'd be like, here's my collusion test. There's no collusion test on an auction that doesn't have any good properties. So it's really hard to assess collusion. You guys understand why this is the case, because it's like, So here's what we did to start. First, we got data on the bids, which was really challenging. We submitted a Freedom of Information Act request to the Center for Medicare and Medicaid Services, and so did Yunnan on her paper. The issue is they won't give us the NPIs, that's the firm level identifiers of the firms that bid in the auctions. I don't know why. They just refuse to give it. They've decided it's private, but only for the bids because they're publicly available information. It's infuriating. So, but we have the firm names. So what we're doing first is we're trying to match from the bidding data into the claims data to figure out which firms we think are fraudulent and did they participate in these auctions. And our goal is to do 3 things. I'm gonna have no results for you here. This is just a spoiler, I got nothing. Okay, so the first thing we're doing is we're testing, are fraudulent firms more likely to bid? That's gonna be interesting, more likely to participate in the auction. The second is, are they more likely to bid low, like close to 0? That seems like a clear test of, like they don't really intend to sell wheelchairs for 25 cents. So that seems like it's sort of a form of gaming. And then the third is, are they more likely to appear to win the auction using the bid level data, but not end up selling anything, which looks like this suicide bidding criteria. So there's a lot of problems with the data here. The lack of NPIs makes things really hard, and it means that we have to group things up to the firm name. The issue is that if our claims data live at the NPI level and our bidding data live at the firm name level, there's some kind of very challenging crosswalking to do. So we're working on that currently. Extremely preliminary, it looks like the fraudulent firms are more likely to have participated in the auction, which is telling us something already, but hot off the presses, don't take it too seriously. Any ideas here for things that we could do? Are any of you like really into bid collusion tests on median price auctions? I don't know what to do with it, right? Like, how do you test for behavior on an auction? So this great paper by Seibel and Škoda, it shows us actually there's not a dominant strategy in these auctions. There are like multiple equilibria, and if there is a dominant strategy in some of them, it's the bid 0, which obviously doesn't work. And so it's like very hard to know how to behave, how to analyze these. And that's sort of Yunnan Ji's paper, the one that we keep talking about. She has like a formal auction model, et cetera. We don't want to turn this into an auction paper for like 3 reasons. The first is there are a couple of good auction papers. The second is we're more interested in these questions about competitive pressure and less about the auction mechanism per se. And the third, because auction referees are really mean on economics papers. Am I incorrect? I'm completely serious. So we want to think about this as competitive pressure, but we do think we need to assess anti-competitive behavior. So we're working on it. We think that this is going to be cool. We don't really have too much yet. Okay, let's talk about quality. This is where there's some more meat to do. Okay, so the competitive bidding auctions award contracts to firms with the lowest bids. Firms are competing on price. They are not competing on quality. Quality is not in the contract. And so this leads us to a very interesting literature, the sort of Oliver Hart incomplete contracts literature, right? There are contractable and non-contractable elements of government procurement, by which I mean there are things that are literally written down, like the price, and there are things that are hard to validate by the government, which is like, who's getting the equipment and is it good equipment, right? And those things are not necessarily easily observable, and therefore they're hard to contract on, okay? There's this great paper on private prisons I mentioned, and the idea is, it's not like our situation where you have multiple firms. They talk about a model is you have the government and a single firm, and they're like, who should run the prison? And they make the point that private firms will cut costs, which can be good if the government's going to be inefficient, but they cut costs too far because they're able to shirk on quality because the government can't see it. And so privatization has this trade-off between you do get lower prices, you also get lower quality, and the quality is not in the contract. That's kind of the goal of that paper. And we're saying here, okay, so what's actually happening is we have firms, they're going to sell durable medical equipment to patients, but there are multiple elements of this, right? The first element is, well, what do I mean by quality? I don't just mean, is the wheelchair broken or not? The government, I'm going to go forward a slide and then I'm going to go back a slide. Quality here is not as simple as whether the thing is broken. The government isn't buying a wheelchair. The government is buying a wheelchair for a beneficiary. And so when the government says, was this a good DME purchase? They're not just interested in the question of, did the piece work? They're also interested in like, did the piece match the patient medical necessity? So quality has these two pieces. There is product quality, right? You have to be worried about them selling literal junk or used stuff like we talked about before, or something that doesn't work. And you also have to be worried about patient match. Are these products reaching the right patients? And we think there are margins on quality for both of these. So let's talk about product quality. If the firm is selling junk, then you might think you could get a little bit more information out of repair rates. Like, is the DME more likely to have been repaired? I can click on this and I'll show you that it does seem like repair rates rise for the fraudulent firms, but it's really hard to know how to interpret that because another reason that firms might have equipment repaired is if people start using it. If you have a wheelchair and you're not using it, it sits in your garage because you didn't need it. And then we move to a world where people use it, then repairs going up is a good thing. So we don't know what to do with those repair rates. Like they move, but what does that tell me? I don't know. The second, where we think we're going to get more action, is on patient match quality. Here's my proposition. It's a lot cheaper to sell DME to a patient who doesn't need it than it is to sell DME to a patient who needs it, for two reasons. The first is patient acquisition cost. If I am just running an ad on late night television, call me and I'll give you a free walker, it's really easy to get patients relative to like finding doctors who treat patients and setting up real relationships. And then you have to actually assess them and figure out what they actually need and then sell them the right equipment, right? And so it's more expensive to run a legitimate firm than it is to just mass market to anyone that you happen to get the Medicare number for. The second reason is that copays are a share of the cost. So you guys know about copays. Under the Medicare program, patients are responsible for paying 20% of all outpatient claims, including DME. Okay, that means that if you're a fraudulent firm and you don't care about the rules and you're just going to give it to them for free, it's very easy to get a patient. If you have to sell a legitimate product and then charge a copay, it's harder to get a patient. And so this we all think about as terms of quality from the government's perspective about what they're selling. Firms that are willing to sell bogus products or broken products to patients who don't need them and not collect a copay, that's low quality, are going to win. They have low costs. They can offer very low cost products. We just brought prices down. To first order, who wins in a competitive market where you bring prices down? The low cost guys, right? And so we think that this is where we're going to get a lot of action. So how do you assess that? We're doing some interesting work here, which is to assess whether or not go ahead.
How do you win in this auction? Like it's a median price,
Yeah.
right? So you have low cost and you're.
Yeah, if you bid below, it's like the lower bidders get to sell, but they sell at the median price. Okay, so one of the challenges here is what you want me to show you is who got the equipment and did they actually need it? And that's hard. It's really hard. Why? DME is thousands of products. It is pumps for lymphedema and CPAP machines and oxygen tanks and walkers, et cetera. And for each different product, we need to say, is the patient who's getting it the right patient? Really, really hard. So we're currently building, go ahead.
Is there a product where it would be cleaner?
We thought about zooming in on a single product. That is our backup option. Our best version involves a lot of work. And so here's what we're doing. I currently have a very talented team of RAs going through all of the coverage determinations, the Medicare documentation, and saying, if you have these diagnoses, then you are eligible for this thing. We are going to start by looking at the legitimate firms in the pre-period. Say, let's look at the clean firms before this thing happened, and let's see if we can build a really robust machine learning model that predicts whether a patient looked like they should and did get DME from a legitimate firm. That's going to give us basically a simple prediction model of who's good for DME and who's not good for DME. And then we're just going to project that model through time and see first, do the legitimate firms look like they're serving the wrong patients? And second, how does that change over time? And so this brings me to what was on my previous slide, but I thought probably came better in the flow here, which is that these auctions are not just going to have selection effects, they're also going to have treatment effects. By which I mean, introducing price competition will not just pick bad firms versus good firms, it will also change the behavior of those firms. And we need to be able to distinguish that, right? We need to distinguish between the firms were bad the whole time, they were bad before, they're bad now, we just gave them market share. Maybe some firms are choosing to engage in more illegitimate behavior afterwards. That's one reasonable story. Maybe some firms are choosing to engage in more legitimate behavior afterwards. Maybe after all the good firms leave, the remaining firms go, well, now we got plenty of real patients to sell to, so I'm just going to sell wheelchairs to people who need them. We don't know. So the idea behind building this, this appropriateness measure is going to allow us to do three things. First, to validate that the firms that we picked out using suspiciousness are bad. Second, to understand how those firms behave, which types of firms based on this other metric are winning across the auction. And third, to assess this treatment effect of the auction. But it's really computationally intensive because we're talking about thousands of patients, thousands of types of equipment. Once you get into the ICD diagnosis space, which is the really most fine-grained code, we're talking about like hundreds of thousands of possible outcomes. Okay.
I have a question about something that's very not computationally intensive.
Yeah, I love this.
Competing frauds. So Medicare Advantage plans have an interest in not paying for wheelchairs people don't need. And they also have an interest in knowing exactly what diagnoses their enrollees have. Have you looked at Medicare Advantage penetration?
No Part C data. So this is a great question, right? So Medicare Advantage is an alternative to traditional Medicare. It means that individuals get sort of a wraparound insurance coverage from an insurer that gets paid a fixed amount per patient, and then they're paying the costs, which means that now you have these insurance companies that are reasonably sophisticated at rooting out bad behavior, and they're responsible for making sure that what happens is legitimate. And so the idea is less fraud happens in those systems, possibly. Reasonable idea. One thing to note is that Medicare Advantage itself has a different type of fraud, which is that the insurer is going to lie about how sick the patient is so that Medicare pays the insurance company more money. And so there's this cherry picking upcoding problem that happens at the system design level, but that's neither here nor there. The issue historically, and I think you know this, is that it's very easy to get Medicare Part A and B fee-for-service data like we're using. It's really hard to get Medicare Advantage data because the private companies administer the claims. It's not as readily available for researchers. My intuition is we'd see less DME fraud in Medicare Advantage. I haven't thought too hard about how it affects our results. One thing that is currently on our to-do list is assessing whether geographic areas that see greater Medicare Advantage penetration have higher or low levels of fraud in the post period.
Yeah, that's what I was wondering about. I suspect there would be spillovers.
I think probably, yeah, but we're not going to be able to see inside the Advantage plans.
Unless, though, I mean, I was going to ask a similar question. If you could see the Medicare Advantage claims, then one thing that would be interesting to look at is, are MA plans giving out as many wheelchairs as?
Probably less. My intuition is
where there's big discrepancies, that's where you sort of, I mean, you use it as a regular.
The issue is that Medicare Advantage plans limit utilization for reasons that aren't just fraud. They just make it harder to get anything because that's like their whole business model,
Yeah, I mean, that's fair, but like even taking that into account,
Yeah.
it seems like it's a useful benchmark.
I will also say, if I can see inside Medicare Advantage plans, I have like 5 other papers I also want to write about fraud. So, no, it's a really good point. It's a really good point. I don't know what to do. So, but penetration at the market level is something we can see. My intuition is that there is different fraud in Medicare Advantage. Particularly as it comes to mischaracterization of patient health overall. In order to, they game the risk adjustment scores pretty hard. There have been a lot of lawsuits against the Medicare Advantage plans for gaming the risk adjustment process.
Yeah, for sure. There's no question that the insurers and Medicare Advantage are engaged in their own bad behavior. But I have this intuition, which I think Ashley must share, and that's why she asked the question, that it's easier to defraud the government as a provider of some kind than it is to defraud a private insurer, because they're going to come after you.
This is my intuition as well. Although I will say, I just met the head of investigations for Kaiser, and Kaiser looks a lot like a Medicare Advantage plan. It's a fully integrated, vertically integrated. It's an employer-sponsored insurance system, but they're integrated. They run their own hospitals, et cetera. And I was like, why do you guys have a fraud investigations unit? And they said, oh, we still have the problem. And it's some amount of they have to contract outside, or even within a vertically or integrated system, people choose to want to attract more resources. I mean, I do think that in general, vertical integration between insurer and provider changes or probably eliminates some of the incentives to commit fraud, but not fully. You can imagine that there's probably still fraud in the national health system of the UK because the hospital wants more resources or something like that. So it's sort of the same argument that like the government still has corrupt bureaucrats, right? Like even though it's a fully vertically integrated system. I've thought a lot about this. But yes, my intuition is that Advantage, I don't think that biases our results, but it does make them less generalizable to other markets. Well, we have to check if they buy it. First, we have to check.
I wasn't thinking of it as a problem. I was thinking of it as a cool thing to look into.
It is a cool thing to look into. And if you know anyone who has a lot of Medicare Advantage data lying around who wants to write a paper. Okay, so much like the other set, I have a lot of ideas and not a lot to show for this. So this is running too. It's hard. We spent a long time just trying to, like, the data got so big that it sort of took us a long time to get to main results. So I hope that this is like a cohesive way that we're thinking about it, right? That there are these 3 things we have to think about. We have to think about whether there are firm level attributes that privilege big firms that happen to be fraudulent. We have to think about whether those firms engage in anti-competitive behavior, like rigging the auctions. We have to think about if there's something about their cost structure that's fundamentally privileging firms with low costs because, like, for example, they're low quality, either in terms of the patients they get or in terms of the products they sell. And that increasing competitive pressure doesn't take care of the quality margin, it only takes care of the price margin, which could select on bad quality. What I'm interested in is if other people have other suggestions about like mechanisms that I should be evaluating that I've missed.
I'll float one.
Yeah.
I don't know if this works. It doesn't sound like this is a high fixed costs industry, but suppose it were. Suppose that there are fixed costs of operating a DME firm, and suppose the regulated rate pre-auction offered a markup over marginal cost that was high enough to cover your fixed cost, but barely. Right? Then the auction comes in, that markup gets bid down, so that it's close to 0. So you're covering your marginal cost, but no longer your fixed costs. The way you cover the fixed costs is by engaging in some fraudulent behavior on the side.
So I think,
and so that would get rid of the honest firms and the fraudulent
100%,
because it's the fraud that keeps them alive.
So I think we kind of get that in the treatment effect under the quality section. What I'm saying, we're going to assess how appropriate the patients are and see how it changes across fraud. Across competition, the introduction of this price mechanism. I think we're going to see 2 things. The first is if the fraudulent firms were fraudulent in the pre-period and fraudulent in the post-period and they just gain market share, that tells us that we're just selecting. But if firms begin treating patients who look less and less appropriate, that's consistent with your story. So we have to distinguish that, right? That's sort of what I was getting at when I talked about treatment versus selection effects. But yeah, there's this idea, right, that honesty is a normal good, right? That people are more likely to engage in honest behavior when there's money floating around and when it gets tight. There's this great paper called Turbocharging. It's by Atul Gupta, Adam Sukharni, and Amber LaForgia. That's about hospitals engaging in payment manipulation. And they talk about how this is actually because of the Balanced Budget Act of 1994, that we cut hospital prices so hard that some hospitals were kind of desperate for revenue. And that's consistent with your story as well. Okay, I have 5 minutes, so let me get a bit into my conclusion. First, my conclusion is longer than 1 slide. So I want to tell you a bigger story. Okay, so I hope I was convincing that fraudulent firms are gaining market share. But is total fraud down overall? That's another question I haven't solved in this paper yet. It really biases the way that I think about this. Like, I don't really, if fraud went down overall, but the wrong companies are winning the auctions, that's very different than if fraud went up, right? Like, those are different worlds. And both of them are bad, but you might feel differently about them for like lots of reasons. And so there's a hard question, because when you do a difference in difference, you get to look at the treatment effect before versus after, but you don't really get long run effects. And what I kind of want is long run effects, right? I want to know, like, in the long run, did this make fraud worse? And I don't know how to assess that. So when I build this big machine learning model to assess whether or not the patients were the correct patients, I will have a better way of getting at the long run. But for now, I have this slide. This is our graph of firms who got caught by the DOJ. This is what we used to build our fraudulentness measure early in the paper, but here's just a time series plot. Do I have a pointer? No. Competitive bidding is here. So it's hard for me to look at this and go, yep, things got better right around here, right? If anything, things kept going up. This is the year that they decided that DME fraud needed to be busted a lot, and they arrested 100 doctors on the same day. Or I think, 100 company executives on the same day. It's called a crackdown. They do these strike force takedowns. But like, over time, it doesn't look like DME fraud stopped, at least using enforcement. Now, enforcement data are a bad measure of fraud for lots of reasons. Enforcement data reflects the government's priorities, how much information they have about bad behavior, their opportunity costs about other things that they could be doing, et cetera. But it's hard for me to take away from this paper, from this figure, that at the end of 2009, fraud was no longer a problem. Yes? So long run, we're worried that actually what happens is we took the market, we shoved out all the legitimate firms, prices did go down, and then you have a bunch of firms who are left who are all fraudulent, and now they're going to figure out new and clever ways to make money. And over time, DME continues to be rife with fraud. So takeaways from this paper, I think beyond studying enforcement, as I've done in other studies, we really do need to understand the conditions that cause fraud to arise and persist. Price competition in healthcare and in other settings doesn't necessarily just get prices down and reduce rents. It can make fraud worse, and we think it has something to do with selecting on the wrong firms. I think this has really important policy implications. This paper is very generously funded by Arnold Ventures, who were kind enough to ask me to look at how lowering prices could make fraud better, and I'm like kind of finding the wrong thing for them. But I think when you think about policy, right, like there's all of this action around let's just get prices better and let's get prices down, et cetera. When you impose low prices on a pre-existing fraudulent market, that actually has different policy consequences here, potentially unintended ones. And I think as we think more broadly about procurement mechanisms and healthcare market design, understanding the relationship between rents and incentives to commit fraud becomes pretty critical for making sure that these programs are able to serve people who are needed. Okay, thank you very much.
Two minutes for questions.
Go ahead.
All right, I want to ask a little bit about collusion. I know you said it's an entire literature, and
Yes.
just, these firms seem to be different firms in their DNA in a certain way.
Yes.
They last in the market. So I don't know. I wonder about the collusion idea amongst these large firms developing different mechanisms to figure out how to, they're almost in like their own different kind of market. So
Yeah.
just.
I wouldn't be surprised. So we think probably there's some amount of collusion. I actually have a hilarious thing. We're looking at the bid data, and one of the bidders is called like DME procurement industries. And it's clearly that they only exist to bid for multiple companies in these auctions, et cetera, right? And so I think it was actually called DME Auction Consortium of North Carolina. Or so it was you shouldn't be making a consortium to bid, right? Clearly if these firms are willing to engage in fraud by selling broken products, by selling used products, by giving products to people who don't need it, it's hard for me to believe fundamentally that they're going to but I won't game this very gameable auction, right? So my intuition is that they're gaming the auctions. It's a specific form of collusion, right? They're not colluding to exclude other firms from the marketplace necessarily. So it's different from other anti-competitive stories. But yeah, bid rigging is a real problem in public procurement worldwide. It's surprising that we find it in the US, which generally has low kind of formal corruption. It's kind of close to real corruption to think about rigging a procurement bid. But yes, I agree with you that these firms have something about them that feels sort of rotten to the core. Yeah. Lots of questions? Go ahead.
Is there one good in this industry, one product that actually has medical evidence that it's necessary and improves patient well-being and.
So all of the products are good products for the right patient. Yeah. That's the problem here, right? Is that like Medicare is very brutal about not paying for things that don't work. The issue is, and like there is patients in this country that need every single product on this list. There are people who need really complicated pumps to make sure that they're, you know, if they have lymphedema, which means that their lymphic system doesn't work, that it squeezes the excess fluid out of their arms. Otherwise, they would have terrible quality of life. And that's true all the way down for everything that we sell on the list. It's not that the product is wrong, it's that the product patient match is bad. And it's really hard for the government to know that. They're relying on the firm to both sell the good, but also in some sense to assess patient appropriateness for that good. And that's where this asymmetric information. Okay, I'm getting that it's time to leave, stand up. So thank you guys very much.